morning, everyone. Matt Bush is my name. I'm at the University of Kentucky. I'd like to congratulate you because you have chosen the most important session of the entire conference. Thank you. Those providers, those leaders who really care about connecting with patients are here now. All the haters are elsewhere. This session is about connecting our heart with our heads and really remembering why we went into hearing healthcare to help vulnerable populations and those that are dismissed and marginalized. So we've got some really exciting research that's being presented from a number of leading institutions who are doing work in this field. So I'd like to welcome first Amanda Davis from UNC, who will talk to us about assessment of equitable representation in clinical cochlear implant research participation. Dr. Davis.
Good morning, everyone. I believe we're still good morning. Like Dr. Bush said, my name is Dr. Amanda Davis. I'm a research audiologist with the University of North Carolina at Chapel Hill. I am thrilled to be kicking off this session with some discussion on representation in cochlear implant clinical research. So here are my disclosures for today's talk. And here is just a quick snapshot of the UNC team. I'm fortunate to call these folks friends and colleagues, so this work that I'm presenting today would not be possible without them. So let's start off with why this topic is important. You may be in the room thinking about, why do I care about what happens in clinical research? And really, the gist of it is clinical research drives the decision-making process for health policies. It serves as a motivator for insurance practices, and it is basically the evidence base that we use to build our clinical protocols and beyond. Therefore, the study design must be intentional and purposeful to be sure that the outcomes that we're using as the decision makers here are equitable. So at UNC, we design our studies with the participant in mind. So we have a purposefully broad inclusion criteria. The study I'm referencing today, the participants are within 18 to 80 years of age. They received a metal cochlear implant, and they passed a cognitive screener. So that is the inclusion criteria for the study we'll talk about today. We also have a very intentional research location. We are centered right in between the hallways of our clinical audiology team and the ENT physicians down the hall. So where our patients receive their clinical care is also where they can participate in research. And then the timeline for research follow-up is aligned with the clinical recommendation at our center. So we see folks on the same day as their clinical appointments, just at that device activation, the 1-month appointment, 3-month, 6-month, and 12 months. So the folks who participate in clinical research are often doing so out of the kindness of their hearts and their desire to make things better for those to come. So we just try to design the study for them and for their convenience. All right. So if you know anything about UNC, you know we are a data-driven center. It is not enough for us to just simply say that these are the things that may allow us to recruit a representative sample. We want to see that on paper. So our primary aim for this study was to investigate whether the study design helps us obtain a participant sample that is representative of the clinical population that we see. And then as a secondary aim, we wanted to know that our clinical population, we wanted to investigate if those folks were also representative of the demographics that we see across our state, as that is where we are sourcing our research participants. So to do this, we took a retrospective look at folks who were implanted in our center from the years of 2019 to 2022 that also met that age categorization, so 18 to 80 years of age. Those folks were stratified into two groups, the participant sample, so those folks who participated in research, and then the general clinical population. And we analyzed the following variables, so age at implantation, biological sex, socioeconomic position using the social deprivation index, their drive time to the clinic location, race, ethnicity, and the rurality of their home environment using the rural-urban continuum commuting area codes. We also, to address that secondary aim, used state demographic data from the 2022 United States Census. All right, so we'll take a quick look at our facility level comparison, so the research group to the clinical population. This is kind of the big spoiler, but we did not see any significant differences for those variables that I mentioned. So the two groups were congruent in age and implantation, biological sex, socioeconomic position, drive time, race, ethnicity, and rurality. So that's the good news, but we'll take a look at those a little more closely. So this is a map of the research participant sample across the state of North Carolina. So we see basically their drive time to our clinic. That's stratified in purple. So the lighter shades of purple indicate that they are coming from closer to the clinical. They were coming from an area that was closer to the clinic location. Excuse me, we can see that in the black there. And then we see the patient distribution across the state. So not surprisingly, a lot of those folks are coming from a central location that is closer to the clinical space. However, we have some pockets of folks that are driving quite a distance to be seen in our center and to participate in research. And the median drive time for these folks was 70 minutes. And then this is our clinical population, so the folks who were just seen by the clinical team. In that same time period, this was their distribution across the state. So again, not surprisingly, a wider reach, but we still see those same pockets of folks coming from major metropolitan areas, especially at the central location closest to the clinic. The median drive time for these folks was 83 minutes, so not a statistically significant difference between those two groups. So we'll take a quick look at race and ethnicity, again comparing the research participant population and the clinical group. Visually, we can see that there is quite a congruency between those two groups. So on the left here, we have the participant sample. On the right, we have the clinical population. This is the racial distribution for both of those groups. And then this is the ethnicity distribution. So the majority of folks seen at our center were Caucasian, non-Hispanic, or Latino, but the distribution of the racial groups and the ethnicity groups were congruent between the two. And this is looking at the rurality of their home environment. So again, whether they're coming from a metropolitan area, a micropolitan, small town, or total rural environment. Again, we're not seeing any dramatic differences between the participant sample and the clinical population. So we'll take a closer look at our clinical sample compared to the state-level demographic data for a few variables. And this is where we start to see some differences. So this is looking at the racial distribution of both the research and the clinical folks all together as compared to the state. I mean, we did see significant differences here. We are closer to parity, and we're taking some efforts to kind of get closer to that, but we did see some differences here in racial distribution, and then the same for ethnicity group, meaning that we are kind of oversampling, or we have an oversample of folks who are Caucasian or non-Hispanic and Latino compared to what we would see across our state. And the same is true for the rurality of home environment. So a large portion of our clinical population, and really the research population as well, are coming from metropolitan areas across the state. We see that, conversely, on the right side of the graph here, that the state of North Carolina does have more representation of small town and total rural environments. So we need to do some more work to basically reach folks from those spaces as well. All right. So in summary, we are pleased to say that our intentional study design and recruitment efforts do help us recruit a representative research participant sample. So we are going to continue to use those strategies and expand upon them as we continue our research. And as we look towards future directions for this work, we're investigating targeted and creative outreach efforts that may help us improve the parity between the clinical population and the state demographics. I would also be remiss in saying that I am very new to this equity research, and so I'd like to say thank you to the folks who have done the hard work in the years before me, especially mentorship from Dr. Bush, And thank you all for your time and attention today. If you're interested in our work here, please feel free to give us a follow on our social media accounts. All right.
Hey everyone, my name is Inderpreet Kaur. I invite you to take a deep breath with me, in and out. All right, so today we'll be talking about a multi-domain national landscape of disparities experienced by DHH kids, and we have no disclosures. Hearing loss affects 1 in 300 US children, and it's associated with speech and language delays, poor academic achievement, and lower quality of life. And given this importance, nationally, there's a critical pathway known as EDI to ensure patient-centered outcomes and health equity. This includes hearing loss identification through newborn hearing screening and diagnostic evaluation, medical workup and intervention, and educational interventions. So we were interested in understanding how DHH kids receive complex care through 2 institutions, medical through access to the medical home, and educational through school engagement. Our data source was the National Survey of Children's Health, which is a cross-sectional, nationally representative survey. And our participants were randomly selected children 0 to 17 years old from randomly sampled US households. The survey was completed by an adult that was familiar with the child, and core content areas included the health and well-being of the child, healthcare access and utilization, and school and after-school experiences. We combined 6 years of the survey data from 2016 to 2021, and using the question, does this child have deafness or problems with hearing, we created 2 main cohorts. DHH kids totaled around 2,700, and non-DHH kids around 222,000, representing a total sample of 73 million US children and adolescents, 0 to 17 years old. The primary limitation of this study is that we relied on this parent report for our cohort definition rather than objective measures of hearing. However, the survey's estimated prevalence of DHH kids was 1.4%, which is aligned with no national prevalence estimates, and this is the only nationally representative data set that allows this analysis. So after defining our cohorts, we performed chi-squared and t-tests to compare demographics amongst cohorts. And here between DHH versus non-DHH kids, there were statistically significant differences in racial and ethnic minority status, federal poverty level, and parental education. For the medical pillar of DHH care, we looked at access to the medical home because for over 2 decades, it's been proposed as a solution by the American Academy of Pediatrics to improve the effectiveness of this pathway and reduce hearing health disparities. A medical home is not a place, but a model for how good primary care is delivered. It's accessible, continuous, comprehensive, family-centered, compassionate, culturally effective, and coordinated with specialized services. And it's recognized as the standard of care for all kids, but especially those with special health care needs, like DHH kids, because they require more care and have more unmet health care needs. And generally, the benefits include better health, lower costs, and ER visits. And specifically for DHH kids that have access to the medical home, they're 3 times less likely to have unmet needs for communication devices, hearing aids, or therapy. But despite considerable advocacy around the medical home and the known benefits, medical home access and potential disparities among DHH kids had not been studied. Thus, we asked the question, among US children with parent-reported deafness and hearing problems, how does access to the medical home and its subcomponents compare to those without deafness and hearing problems, as well as those with other special health care needs? For this analysis, we used 3 cohorts: DHH kids, non-DHH kids, and children with other special health care needs that weren't DHH. We dichotomized the medical home composite metric as well as each of its subcomponents. And since the demographics were different among cohorts and have been shown to affect medical home access, those variables in purple we dichotomized and included them as covariates in our multivariate logistic regressions. We found that DHH kids were 0.74 times less likely to receive care in a medical home compared to non-DHH kids, and 0.71 times less likely compared to other special healthcare needs children. For percentages of each outcome, DHH kids, the orange bars, were less likely to have care in the overall medical home, 37% versus 48% for the non-DHH kids, the green bars. And they were also less likely to receive family-centered care, needed referrals, and effective care coordination. Next, we looked at school engagement. And we looked at two components: extracurricular activities, sports, clubs, volunteer work, paid work, and organized lessons, and educational performance, which included repeating grades, missing school days, being contacted by the school about problems, not caring about doing well in school, and not doing required homework. Similarly, for this analysis, we used DHH versus non-DHH kids. We dichotomized each of the school engagement and demographic variables and included them as covariates in our multivariate logistic regressions. After adjusting for those demographic covariates, DHH kids were statistically significantly less likely to participate in all extracurricular activities besides from clubs and organized lessons. For example, they were 0.73 times less likely to participate in volunteer work, with 31% of DHH kids participating versus 41% for non-DHH kids. For all educational performance variables, DHH kids were statistically significantly performing worse. For example, 1.8 times more likely to repeat grades, 12% repeating grades versus 6% for non-DHH kids, and 3 times more likely to miss school days, with 12% of DHH kids missing versus 4% of non-DHH kids. We then did a mediation analysis of repeated grades, since we know being DHH is associated with speech and language disorders, and kids with speech and language disorders are more likely to repeat grades. A mediation analysis enables us to understand, or to say, how much of the effect of DHH status has on repeated grades is mediated through having a speech and language disorder versus being a direct effect on repeated grades. We found that only 24% of the effect of repeating grades is mediated through having a speech and language disorder, meaning DHH itself, not just because of the effect on speech and language disorders, is associated with grade repetition. Thus, as a nationally representative study for educational-related DHH outcomes, we can say that parent-reported DHH kids are less engaged in school. For 8 out of 10 variables, they had significantly worse engagement. Second, being DHH itself is driving certain outcomes, such as repeated grades. Thus, more DHH-specific accommodations, such as FM systems, seating changes, and teachers for the deaf and hard of hearing, are needed to improve the inclusion and involvement of DHH kids in school. For the medical home side, the medical pillar of DHH care, we found that given the medical home is meant to be the standard of care for all kids, results show nationally there needs to be improvement in medical home access for all study populations because no medical home percentage was 100%. However, in adjusted models, DHH kids felt the most disparities in access to the medical home and also less family-centered care, ease of referrals, and effective care coordination. Given DHH kids are worse off than other special healthcare needs children, there may be increased complexity or unfamiliarity with caring for a DHH kid in the medical home. So how can we improve medical home care for DHH kids? One example for improving medical home care is having more effective care coordination. And to learn more about a potential solution, I invite you to come hear my colleague, Dr. Michael Lindenborg's talk on the effectiveness of a patient navigator to improve EDI outcomes on Saturday at 12:20 p.m. Thank you so much.
Good morning. It's a pleasure for me to be here sharing with you. I'm Sandra Berlandia from University of Miami. I'm going to speak about the evaluation of the comparative validity of Spanish and English assessments in bilingual cochlear implant recipients. I don't have any relevant disclosures, and I would like to acknowledge my research collaborators. So the Spanish-speaking population is rapidly growing, predicting that the United States will be the largest Spanish-speaking country in the world by 2050, with a significant increase in patients with limited English proficiency. This is linked to healthcare disparities. Therefore, clinicians need linguistically and culturally appropriate assessment tools for accurate hearing evaluations. And while these tools are on the rise, little is known about the validity and equivalency of these materials compared to the English language tools. If we look at these stats, people that migrate from Spanish-speaking countries, adults, only 38% learn English. There are many differences between English and Spanish languages, but I don't have time to discuss those differences now. However, this may affect the access to hearing treatments such as cochlear implants. So the Spanish HINTS and more recently the Spanish AC Bio are the only Spanish tests that we have access to determine cochlear implant candidacy, but the equivalency of these measures has yet to be evaluated in bilingual speakers. The first impression that I had when I applied the Spanish AC Bio sentences were that the vowel noise that they use is in English. Then we performed a study introducing that condition with a Spanish AC Bio with a Spanish vowel in normal hearing bilingual subjects. And what we found was that there was a significant differences between these three conditions, English AC Bio and Spanish AC Bio with English vowel and Spanish vowel. Then we performed this study when we want to examine the equivalency of the English and Spanish AC Bio and hearing in noise tests in bilingual English and Spanish cochlear implant users. We assessed 17 Spanish and English bilingual adult implanted cochlear implant patients, and the ages range from 18 to 75 years of age. The mean age was 49 years. We used the English and Spanish adapted hearing in noise test. We performed this test at 60 dB SPL, and we determined the signal-to-noise ratio required for listeners to achieve 50% speech discrimination. We also used the English and Spanish AC Bio. We presented at 60 dB in fixed SNRs from -2 dB to +12 dB in 2 dB increments. And these are the results of the 17 patients. So we can see here in the y-axis, I can point, let me go back. So we can see here the percent correct scores, and in the x-axis, we can see the SNRs and what we present the different testing. In the blue squares, we can see the mean percent correct scores, and the arrow bar represents the 90% confidence interval of the mean of the results. Then we fit this in a psychometric function curve, and then from here, we extract different values and variables. Then here, we're going to analyze the first one, that is the theta, or the midpoint of the curve, that is the most sensitive point of the curve. For English AC Bio was 6.5 dB, and we're going to see that is different from the 50% speech discrimination, and this is because this doesn't achieve 100% discrimination for the English AC Bio. So in English was 8.4 dB. Now we're going to analyze the omega, or the width of the psychometric curve. And this is to determine how difficult is the test, or how easy is the test at each SNR. And for the English was 9 dB. Then we're going to see here the lambda, that is the maximum score that these subjects can achieve in this test. So it's 30% for English AC Bio, meaning that these subjects only obtain 70% at this test. Now we're going to compare the English AC Bio with the Spanish AC Bio. In green, we're going to see a Spanish AC Bio with English vowel, and in purple, we're going to see with a Spanish vowel. And the first thing that we're going to analyze is the 50% speech discrimination. So here, we're going to see that English AC Bio is significantly different than the Spanish AC Bio with English vowel by 3.6 dB, and is by 3 dB with the Spanish vowel. We also see the lambda value that is 20% in Spanish and 30% in English, meaning that in Spanish, the subjects obtain 80%, while in English, they obtain 70%, meaning that the test is more difficult. Even though the difference is not significant, the test was more difficult in English AC Bio for the same bilingual subjects. When we look at the slope of the psychometric function, we see that the Spanish test has a steeper slope, meaning that the subjects can get more words correctly faster in a more difficult SNR. And then when we look at the width of the curve, it was 9 dB for English, while it's 7 dB for Spanish, meaning that English is also more difficult. There was no significant difference between the English and Spanish vowel because we're working with hearing impaired systems, and we are also working with patients that have cochlear implants. So they couldn't discriminate in the vowel noise between English and Spanish. We also compared the hence sentences. In green, we see the hint sentences in Spanish, and in blue, we see the hint sentences in English. And this difference was also significant, demonstrating that there is a significant difference, English being 8.5 dB more difficult than Spanish. So we see that AC Bio and hints is more difficult for English versus Spanish. Here, we analyze by groups, bilateral cochlear implant users, unilateral cochlear implant users, and bimodal. And what we see is the same trends. Even though it's not significant in every group, we see the same, that the Spanish test is much easier than the English test for the bilingual cochlear implant users. So we presented significant differences between English and Spanish per test. And this is important to analyze clinically, because if we look at the signal-to-noise ratio that we use in clinic, +6 and +10, we see the significant differences between English and Spanish in these bilingual subjects. And then we see that Spanish AC Bio yielded up to 30% higher scores when compared to English. We see that the slope of the psychometric curve for Spanish AC Bio is significantly steeper than the English, meaning that the subjects can get more words correctly and faster in a more difficult SNR. And the adapted hand recognition scores differ by around 8 dB between Spanish and English, being more difficult for English. So the future considerations for test design between languages, were the tests equally designed? Are the acoustics and phonetic cues of each language causing these test differences? These are all future considerations to improve equity in CI candidacy and audiological evaluations in general. Thank you so much for your attention.
It's on now. Thank you. Thank you so much for those talks. We really appreciate it. Very interesting. We'd like to open the floor to questions.
There's a mic over there.
There's a mic. Yeah.
I'll ask a question while he's getting to the mic. So, Sandra, thank you for that presentation. I mean, this is critical to understand, are we doing the right test for the population that's appropriate for them? But my question would be, how do we know which test to give to which patient? That they may say and identify as bilingual, but what might be the appropriate test? What are your impressions from your findings?
So now that we have the Spanish AC Bio, is a little better than when we had only the hints, because with the hint was more difficult to qualify patients, and we have to perform the hints all the way to 0 dB SNR. And it was not just to qualify patients, because we wanted to implant them. It was just trying to show the difficulties that they had in real life, because the hand test is so easy that we were not seeing the difficulties that they have in real life, because they don't walk with a booth around them to invite people, come inside the booth so we can have a conversation. So with the Spanish AC Bio, it's easier to qualify them, but I show you the differences. There is a 30% difference. So you have to analyze what is, like in my case, Spanish is my primary language, but I have to conduct business in English, because many of my coworkers most of my coworkers don't speak Spanish, so I have to speak in English. So in that case, I should be evaluated in English versus Spanish, but sometimes you have to evaluate patients in both. We do bisyllable words and CNC words and compare and look at the differences, and also both Spanish AC Bio and English AC Bio, and then analyze how they do in quiet and how they do in noise, and take determination based on that.
Thank you.
Hello. Great presentations, everyone. I'm David. I'm a resident at WashU. Question for soon-to-be Dr. Khalsa. Great presentation. I had a question about your repeat grades analysis. I think parent-reported DHH kids repeat grades, but only 24% of that is from their speech and hearing-related issues. Was there anything in the data or in that analysis that hinted at what the other 76% was?
No, so unfortunately we're limited by kind of essentially what the survey asks, but basically the way the mediation analysis works is just you see what the total effect of the, essentially what the result is, and then you can piece out, how much of it is partially versus fully mediated, and if there's any mediation. And so the stats essentially worked out like that. It gets a little bit more at mechanistic, but there's nothing in there that explains why. We did have theories about particularly like additional academic stresses that DHH kids are probably having, like listening fatigue and other things like that, that might not be captured. So we don't really know what is the underlying factors behind DHH status that are leading to these outcomes. We just know that there's a relationship between the outcomes, and that the relationship is primarily being driven by DHH status, if that answers your question.
That does. Thank you.
No problem. Thank you.
Hi, I had a question regarding the Spanish and English testing. I wonder if there's been any interest at your center in trying to identify which test battery is more appropriate based on the patient's self-reported proficiency in one language or the other.
Yeah, so we analyze different things when we decide what test to use, and one is the language proficiency, the age at what they start learning the second language. Also, what is the language that they use most of the time, especially to conduct business or daily life. And sometimes we have to use both languages to assess. Something that I look is at how they do in noise, because we know that cochlear implants are very good in quiet, but in noise, there are still difficulties. So if I see that in Spanish AC Bio, they are doing well in noise, I may ask them to have a hearing aid trial and see how they do before I transfer them to a cochlear implant, or I may consider for them to keep being bimodal so they can get the best of the cochlear implant and the hearing aid before they go for bilateral cochlear implantation. Just because if they are getting benefit in noise, I don't know if they will get the same benefit with two cochlear implants. So those are different things that I consider when I have a Spanish-speaking or a bilingual cochlear implant patient.
I'll ask one more question. Sorry. These are my heroes here. This is important research. Dr. Davis, thanks for your presentation. and for your transparency. This is important that we're, not recruiting, what's representative of our populations, and we can have to be careful about what conclusions that we make and the challenges, but I'm really interested to hear, a sneak peek of what you're doing to try to reach out to those populations, whether that was in the geography or those communities, that might be increase the equity of research.
Yes, a very excellent and important question, and I would say it's something that our team thinks about a lot, especially as we're considering how to address some of these disparities and what we're seeing represented in our clinic. I feel like we've taken kind of two approaches of how can we get folks to come to us, which is improving our outreach as far as making sure that medical professionals across the state are aware of the options of cochlear implants for their patients, and really increasing our presence on social media and improving accessibility in that regard, but also how can we get our folks out into the community as well. So we've used satellite clinics in different locations across the state. We've also created a collaborative clinic network, utilizing the expertise of audiologists across the state for our patients. And then also a recent establishment of a mobile unit that will start traveling across the state, especially to see folks, our really pediatric patients with hearing loss as well. So those are just the beginning efforts, and I'm excited to keep thinking about how to improve this.
Thank you.
Hi there, my name is Rebecca Bell. I'm a PGY4 at Dartmouth in New Hampshire, and I just want to thank Dr. Valandia for so beautifully queuing up my talk. And I want to thank the ACIA for this opportunity to present our research exploring the associations of primary spoken language and individual perception of hearing-related disability. This was a collaboration across many institutions, and I just want to thank all of my co-authors for their mentorship. I have no disclosures. So we know that almost 70% of the US population by age 70 experiences hearing loss, and despite a similar prevalence of hearing loss between individuals identifying as non-Hispanic white and those identifying as Hispanic or Latino, individuals of Hispanic or Latino backgrounds are 78% less likely than English-speaking individuals to use hearing aids, and 50% less likely to undergo a cochlear implant. Numerous studies have tried to elucidate why these discrepancies exist. Theories exist regarding access to healthcare, socioeconomic status, and the availability of quality healthcare information. However, recent studies have also begun to explore the influence language used for audiometric testing may have on perceived candidacy for treatment. So particularly important was this study by Dr. Valandia, and we have some new data today as well, that identified that bilingual patients performed better on sentence testing and noise when tested in Spanish than English. And it might be reasonable to believe that English speakers may be more likely, as a result of this, to qualify for a cochlear implant than those tested in Spanish. These observations might be partly explained by inherent differences in language syntax and the presence of more high-frequency phonemes in the English language, and as we know, presbycusis tends to affect the higher frequencies first, and that may result in the English language being more difficult to understand with the most common patterns of hearing loss present. So our hypothesis is that as a result of these discrepancies, primarily Spanish-speaking patients may be less likely to report hearing deficits than primary English-speaking patients. And if present, this could lead to significant healthcare utilization patterns and changes. So in Spanish-speaking patients, we may see them pursuing hearing intervention at a lesser rate, but then continuing to be challenged in their social, academic, or work environments to interpret those higher frequency languages such as English. So in order to study this, we used the National Health and Nutrition Examination Study data, the NHANES database, which is a national publicly available data series that includes a series of in-person interviews, health status questionnaires, and general health metrics from the US population. And included in this database is demographic information regarding gender and age and ethnicity, as well as questions regarding general health and audiometric data, as well as otologic health and tympanometry results. So the NHANES surveys are also translated into Spanish in a culturally sensitive context, and participants are offered the opportunity to conduct the interview in Spanish based off of their preference. So our primary outcome was the patient perception of hearing-related disability, and this was measured by responses to 3 questions. So you have, how frequently do you have difficulty following conversation if there's background noise? How frequently does your hearing cause you to feel frustrated when talking with members of your family or friends? And how would you assess your hearing without a hearing aid or other listening device? Responses were dichotomized, as you can see here, for the purposes of a multivariable logistic regression. Primary spoken language was our primary dependent variable, but we also adjusted for age and gender, highest degree of education, PTA, and self-reported general health to mitigate for confounding influences. Multicollinearity was assessed by calculating a variance inflation factor, and none of the included variables were determined to be collinear. Patients were included if they had a complete questionnaire, audiometric response, and had normal tympanometry and otologic exams. So we had about 4,690 complete responses in the NHANES database from 2015 to 2020. Of those participants, 600 spoke Spanish. Age and gender was fairly well matched. PTA was similar, around 2% in both cohorts reported using hearing amplification devices. Almost all of the primary Spanish speakers identified as Mexican American or Hispanic. And other notable differences between the groups was that there was a larger portion of primary Spanish speakers who reported having a high school degree or less and described their general health as poor to fair. So looking at our regression model results, so we found that speaking Spanish was associated with a 42% reduced odds of a patient reporting difficulty hearing or understanding in background noise, a 28% reduced odds of a patient reporting feeling frustrated when talking to a family member or friends due to issues related to hearing, and a 31% reduced odds of a patient describing their own general hearing as a little trouble to deaf as compared to participants who spoke English. Importantly, again, these observations were independent of those variables we included, so age, gender, highest degree of education, better hearing ear, PTA, and self-reported general health. Because this is kind of a double negative and difficult to follow, I'm just going to restate this, that Spanish speakers were less likely to complain about their hearing independent of PTA and other health concerns. In an attempt to investigate any overlap between primary spoken language and self-reported ethnicity, we did include ethnicity in a sensitivity analysis, and with ethnicity added, we see that the effect of speaking Spanish on a patient perceived hearing disability is attenuated but persists. The effect on the question regarding talking with family and friends due to and frustration with talking to family and friends due to hearing was no longer significant. But these findings suggest that ethnicity may influence some of this association between primary spoken language and hearing-related disability, but cannot entirely explain this finding. We also performed a sensitivity analysis which filtered for hearing loss with a PTA greater than 25 decibels for the better hearing ear. And again, the results persisted for the first 2 perception of hearing-related questions, but was attenuated for that 3rd question regarding general hearing description. So unfortunately, just the nature of the NHANES data, this is likely just secondary to sample size deficiency, and we would recommend that this analysis be performed on a more robust hearing loss population, and particularly with a more even distribution of Spanish and English speakers. So to summarize kind of the results of our study, we found that participants who speak Spanish are less likely than those speaking English to report difficulty following conversation and noise, frustration related to hearing loss when speaking with friends and family, and describe their general hearing as problematic. And I'm just going to pause here to say that my co-authors and I acknowledge that there's a lot of nuance to primary spoken language, and that this should be addressed in future studies, that Spanish is spoken by 13% of the US population, and it's the most common non-English language, but it's also spoken by many ethnic subgroups with many dialectical differences, which may also contribute to perception of hearing-related disability. And so future studies should kind of address that discrepancy as well. So just to summarize kind of the impact of this, as I mentioned earlier, we know that there are rates of hearing intervention are lower in the Spanish-speaking populations. And as we think about factors that might decrease or increase hearing loss intervention in those populations, it's important to continue to target those socioeconomic disparities, access to healthcare information, as well as continuing to adjust our audiometric assessments to meet those language-specific needs of our patients. But the results of this study also suggest that we may need to adjust our interventions to cater to the fact that Spanish-speaking patients may have a decreased perception of hearing-related disability, and that we may want to incorporate this kind of patient-centered metric into our audiometric testing protocols and assessments for candidacy for interventions like cochlear implant. So again, just wanted to thank everyone for their time, all of my co-authors for their mentorship, and we'll take questions at the end.
All right. Well, I wanted to thank the Planning Committee for giving us an opportunity to get up and speak today. My name is Sean Stevens. I'm a neurotologist in Phoenix, Arizona at the Barrow Department of ENT, relatively new department that we started a few years ago. We wanted to start speaking and getting information out about our Native American population in Arizona that we've been treating, because we've been seeing some significant disparities in healthcare and access to care in that particular population. And it turns out there just isn't much out there on that. So we're going to be discussing today our cochlear implant candidacy, clinical profiles, and as much as we can of surgical outcomes, specifically looking at our Native American patients compared to our non-Native patients. Quick disclosures, I am a consultant for Cochlear Americas, but there was no direct conflict of interest regarding this talk. And also these thoughts and ideas presented in this presentation do not directly reflect those of Indian Health Services or the Phoenix Indian Medical Center, who collaborated with us to treat these patients. A quick background on the Barrow CI program, and this is not to sell ourselves, but really just to give an idea and context to what we're talking about. Our program is relatively new, so I came out to Phoenix and started professionally in private practice about 7 years ago. During the pandemic, I was offered the opportunity to start a new ENT department at Barrow Neurological Institute, traditionally known for its neurosurgical programs, and we did decide to take that job. Currently, we have one neurotologist, our second starting later this summer, 4 full-time audiologists, and in between 1 and 2 audiology externs. So a relatively new and young program, rapidly growing. We're based in central Arizona in downtown Phoenix. It's a very busy clinical program. You can see the number of surgeries there. And about 10% of all of our patients, it turns out, identify as Native American. Arizona is home to a very large number of Native Americans. It's actually the largest by population of anywhere in the United States. We have 22 federally recognized nations in the state of Arizona, which is a 3-way tie for second place. California is the most. And of those, 3 of the 5 most populated nations do happen to reside mostly in Arizona. One other quick caveat here is, for the purposes of this talk, we're going to use the term Native American interchanged with Indian Health Services. It turns out actually that most Native Americans actually do not prefer that term, as I looked this up. They actually prefer to be named by their tribal affiliation. Now, Indian Health Services also has a very strict policy that you have to get special approvals to be able to refer to individual tribes, which we didn't have in time for this presentation. So we're going to use some generic terminology moving forward. Some of the unique barriers to care for this population, these numbers were shocking to me as I looked this up, is that a very large proportion of these patients do not have access to just common services. So things like electricity, internet access, even just living above the poverty line. These numbers are very, very stark. So in Arizona in particular, 21 to 35% of our patients have no ready access to electricity. So you can see there's definitely some disparities in care there. There's also little research on this, it turns out, in terms of hearing healthcare disparities. The best studies I was able to find demonstrate that this population, in addition to a very large disparity in chronic ear cases, is also about double the incidence of hearing loss among adult patients. So the problem is there, the population is large. We also face some significant geographic hurdles. So in Arizona and the Southwest region, which we'll be discussing of the United States, there are very, very large distances. Most of the reservations are actually very spread out, and a lot of these patients have to travel quite a way to get to us centrally in Phoenix. So the problem that we've tackled and the way we've gone about this in the Phoenix area is we started working almost immediately with decentralized networks. So specifically, I'm going to refer to these as CPNs, or cochlear provider networks. We had a talk yesterday on this, but this has been very paramount for us to be able to reach our population of patients in a wide geographic region. And then specifically, I want to get a shout out to our colleagues and partners at Phoenix Indian Medical Center. The audiology team there has just been fantastic. They helped us to build this program to treat our Native American patients. The CPN models, for those who aren't familiar, can do a number of things, but for the purposes of this talk, the majority of our CPN providers actually do all the workup and they do all the programming for us. So it allows these patients to stay a little closer to their home locations. So that'll be important later in the talk. So our objectives with this study were to explore CI candidacy workups and access to care and things listed on this slide. And specifically, we wanted to compare those outcomes to those patients who are of similar background or similar referral models, other CPN patients who are non-Native American, and then our patients who are just worked up through our Barrow CI program. These are our methods. Probably the biggest thing to know is that we have 3 comparison groups for the purposes of this study. So we're going to refer to our Native American patients as IHS, that stands for Indian Health Services, very broad designation, but just so you know, that captures that population. We'll be comparing those to our patients who were also referred through a CPN, and then our Barrow-only CI patients. And then the data points that we compare are here below. The other thing to point out is our audiometric data is limited, and there's some limitations to how a CPN model works with data collection, IRB, data reporting. So what we report here is limited, but we'll do the best we can to look at outcomes. So our Native American profile, currently 52 patients have been under evaluation since 2021. We get about 15 to 18 new patients per year, and this is about 10% of our entire practice on a per annum basis. Of our CPN partners, we end up having a large number of patients get both worked up and then programmed by these providers, which really helps us reduce the number of visits and keep our relatively small team very, very productive. Looking at our descriptive statistics, the biggest take home from this is that our Native American patients tend to be elderly and they tend to be female. And there's a couple reasons we think for this, but one of those is that life expectancy among the male population is actually quite a bit lower in this group than it is for others. So this didn't reach significance, but we think as an overall trend, that probably is real. In terms of surgical conversion rates, so defining this is a patient who goes through the pathway and eventually gets to surgery. We see that the conversion rates overall for our CPN program, so any patient non-Native American, is actually quite good. So we're getting about 80% plus of those patients out to surgery, whereas in the Native American patients, it's actually much, much lower. So we're looking at about 57%. That difference was significant. Looking at the attrition rates, so basically those patients who don't go to surgery, we've been able to track this data. The 2 biggest reasons this particular population doesn't seem to get to surgery is either patient choice, and that's actually quite common, meaning that they qualify for a CI, but they themselves choose not to go down that pathway. And then also just general loss to follow-up. They disappear. So they may go through the testing and they never make it back to me to ever even discuss it. And there's quite a few reasons for that. We'll get to that in a second. The other thing that we see is looking at visits by our group and time to surgery, that these patients actually, because of our CPN model, we're able to keep those number of visits low because we can decentralize back that to our partners. Our time to surgery, typically we'll have a big range with this population, but we tend to be about a month better than our average patient. And again, that's more a nod to our CPN partners than it is necessarily to the Native American population itself. Now, this is probably one of the biggest disparities is the distance traveled. So a centralized geographic practice, they have to come quite a distance, and you can see the huge range here. This has been a real concern because a lot of these families share one single car for 4 generations in one household, or sometimes don't even have a single vehicle and have to use IHS services to get in. Outcomes-wise, and again, take this slide with a grain of salt, we just don't have enough data to really show robust outcomes here. You can see that the Indian Health Service or the Native American patients actually do quite well, so they're comparable. We're going to try to improve this, but again, this has to do with time and logistics, and if they're going to come down for a visit, we don't want to use a lot of that transportation time in testing if we already know the patient's performing well. So a couple other key findings: great retention rates. We see that all of our patients are speaking English, but we are encountering a lot of native dialects. We do have some study limitations, the retrospective nature, there's patients still in phase. But overall, this is the first ever study to our knowledge that's ever looked at this, and we have a lot of work to do. We're excited to see what this patient population is able to achieve and some of the hurdles of care and how we approach that. So thank you again to the Planning Committee for the chance to speak.
Thank you very much. I would like to thank the ACIA committee to allow me to present our work, the influence of social determinants of health on the progression from cochlear implant candidacy to implantation. My name is Estefania Candelo. I'm a former research fellow at Mayo Clinic, Florida, and currently I'm a PGY1 at University of Washington. Cochlear implantation is reportedly severely underutilized by eligible individuals. This deficiency in access might be related in part to the social determinants of health, also known as DOH. For that reason, our aim is to explore the association between self-reported SDOH factors and the rate of progression from cochlear implant evaluation to implantation. And secondly, understand the association of these SDOH factors with propriety-aided speech test score and quality of life measures. For that reason, we performed a retrospective study in Mayo Clinic Enterprise between 2021 and 2023. The inclusion criteria comprises patients that underwent cochlear implant evaluation and completed an SDOH self-reported questionnaire. The social determinants of health are the risk factors that have been identified associated with morbidity and mortality by the WHO Commission of Social Determinants of Health. Mayo Clinic implemented an internal self-questionnaire to understand the full spectrum of these social determinants of health in our population. These include physical activity, stress, housing stability, financial resources, social connections, food security, and intimate partner violence. For this study, we divide our cohort in those who underwent cochlear implantation and those who did not. Then we compare the two groups based on the demographic characteristics, the preoperative aided speech test score, including CNC words score, AC-BIO in quiet and noise, and cochlear implant quality of life 35. For the analysis, we understand the distribution of our data using the Shapiro-Wills test, and according to that, we use different statistical tests, including chi-square, Mann-Whitney, Kruskal-Wallis, and the effect of the size association was calculated by using Cohen's d. The outcomes included the prevalence of SDOH factors, the difference between speech perception scores, the difference in quality of life scores, and the time to cochlear implantation. In our cohort, we included 384 participants. The average age was 68.7, with a male to female ratio from 1.2 to 1. 77% underwent cochlear implantation, and 22% did not. Based on the sociodemographic characteristics, in the group who underwent cochlear implantation, there was a greater proportion of white participants than in the group who did not undergo implantation. And there was a greater proportion of individuals who attained a college education among those who underwent cochlear implantation compared to those who did not. According to the SDOH risk factors, we found the most frequent SDOH risk factor was physical inactivity, with 67.4%, stress with 27.7%, and poor social connections with 25.5%. We also found a higher prevalence of social disconnectedness in the group that did not undergo cochlear implantation with 32% versus 22% in the ones that underwent cochlear implantation with a p-value of 0.011, and higher physical inactivity in the group that did not undergo cochlear implantation with 67% versus 64% in the one that underwent cochlear implantation. Regarding the time to cochlear implantation, there was no difference in the wait time from cochlear implant evaluation to implantation between patients with at least one SDOH risk factor. There was no difference in the wait time from cochlear implant evaluation to implantation between patients with stress and those without stress. But physical inactivity was associated with a longer wait time from cochlear implant evaluation to implantation. Patients with inactivity waited 12.1 months, whereas patients with some level of physical activity waited 6.12 months. We didn't find any difference between groups in the audiometric outcomes. However, we found that patients reporting loneliness had lower CNC scores compared to those reporting appropriate social connectedness. Patients experiencing financial strain had lower CNC word scores compared to those that were not experiencing financial strain. Patients with stress had lower CAQL-35 scores than patients without stress, and no significant difference in speech reception threshold, word recognition, RPTA, ACVI scores were found between patients with and without SDOH risk factors. The limitation of our study stems for the use of retrospective data and medical charts as our primary data source. Additionally, the population that we are including in this study does not represent the national trend, but allow us to model the association between SDOH risk factors and the audiometric outcomes and the progression from cochlear evaluation to cochlear implantation. This is the largest cohort aimed to determine the association of self-reported SDOH factor with the progression from cochlear implant evaluation to cochlear implantation. We found racial and educational disparities in the progression from cochlear evaluation to implantation. We also found that physical inactivity and poor social connections might be a risk factor for lack of progression to cochlear implantation. And the most self-reported SDOH risk factors do not appear to impact the time between cochlear implant evaluation and implantation. However, physical inactivity might be a marker for risk of delays between evaluation and implantation. For that reason, we consider that clinicians should consider first assessing CI candidates' level of physical activity and SDOH risk factors to identify patients at risk of delays in cochlear implant care. And secondly, assessing the stress to understand the degree of impact of hearing-specific quality of life deficits. I would like to thank my mentor, Dr. Raymond, for guiding me in this work and to allow me to present this work today.
Hi, my name is Miriam Smetak. I am a second-year neurotology fellow at Washington University in St. Louis. Dr. Hsu was supposed to present today, but unfortunately was unable to make it, so I'll try to do my best to live up to a project that's really important to him. We have no conflicts of interest to report. So health outcomes are driven by a complex interplay of innate biological factors, social, environmental, and economic factors. Social determinants of health are non-medical factors that influence health outcomes and account for 33 to 55% of these outcomes and premature death. Social determinants of health can be broken into roughly 6 domains, including healthcare access and quality, education, social and community context, economic stability, neighborhood, and physical environment. Social determinants of health have well-established influence on many chronic conditions, including diabetes, cardiovascular disease, and hearing loss. Disadvantaged groups tend to present with higher degrees of hearing loss and are more reluctant to seek treatment. Prevalence of hearing loss is higher in patients of lower socioeconomic status, and adults with hearing loss are more likely to be unemployed or to earn a lower income if they are employed. So it's critical that we understand the impact of social determinants of health on hearing loss and specifically on our patients with cochlear implants. So social determinants of health have been shown to have a negative impact on CI healthcare access. So lower socioeconomic status patients are more likely to qualify for cochlear implants, meaning that their referral for a cochlear implant in the first place is delayed, and they're less likely to proceed with a cochlear implant even when they are candidates. Non-white race is associated with an increased time to CI. Social determinants of health have been shown to negatively impact pediatric outcomes across the board in terms of presentation, matriculation, and speech perception outcomes. And a lot of this may be driven by that delay in time to implantation because it's so critical to implant these children as early as possible. But the impact of social determinants of health on speech perception outcomes after CI in adults is still unknown. So the objective of this study was to look at whether social determinants of health impact post-implantation speech perception outcomes in adults. There's some challenges to this. Social determinants of health is not a simple thing to measure. It's a complex and broad framework encompassing all of those domains that we talked about. So how do we capture this? So we use the National Area Deprivation Index, or the ADI. This is a single measurement of neighborhood disadvantage status calculated across the 17 domains of social determinants of health. It's based on a 0 to 100 point scale, where 0 is the least disadvantaged and 100 is the most disadvantaged. And you can pull this using 9-digit zip codes, which are available in every EMR. So we have a workflow integrated CI data registry that we use, has a little over 1,000 patients in it. We looked at adult patients who underwent CI between 2016 and 2022 and excluded pediatric patients and then patients who didn't have preoperative or postoperative speech testing, and then we excluded surgical revisions. So overall, we had 658 patients that met criteria. We pulled their national ADI, and we looked at change in CNC at 3 months. The reason we chose change in CNC is because our patients with who are more disadvantaged tend to present with worse hearing to begin with, so we wanted to look at the difference rather than an absolute. We did a multivariable regression with factors that we know are associated with performance, including age, pre-op PTA, duration of deafness, and data logging. This is our cohort. I want to draw attention to a couple of things here. So again, 658 patients, 627 of which are Caucasian. So there's clearly some access discrepancy here. In terms of insurance, the states that are serviced by Washington University and St. Louis are primarily Missouri, Illinois, Indiana, and Arkansas. In none of those states, the Medicaid programs, so in all of those states, the Medicaid program does not cover cochlear implantation. So for the simplicity in the study, we separated into government and private insurance. This is our overall speech perception outcomes for the entire cohort, looking at CNC and AZ Bio in quiet, and then AZ Bio bilaterally in noise. So we did a multivariable regression analysis. We did it twice, once with data logging and once without data logging to include those who didn't have data logging, and it didn't change our conclusions. We did show, as you'd expect, that age at cochlear implantation, duration of hearing loss, and pure tone average all do have a significant impact on outcomes, although the effect is small. Insurance status has a very significant effect on speech perception outcomes, but we did not show a statistically significant effect from ADI or from race, and that the race component may be because we have such a small cohort of non-Caucasian patients. So we thought more about why does ADI not show a statistically significant effect here, and is there something going on with insurance? So if you look at ADI and insurance as independent factors. You can split the data into two groups, government and private, and you show that ADI does not have any significant impact on delta CNC at 3 months. But what if you look at the interaction effect between the two? And here we see something interesting. So the interaction between ADI and insurance is significant. So patients, as their ADI gets worse, as they become more disadvantaged, that insurance status becomes more important. So patients with private insurance who are in a very disadvantaged neighborhood do better than those who have government insurance. So what does this mean? I don't really know, honestly. It needs to be critically explored. So could this be a surrogate marker for patient motivation, psychosocial support, economic stability? There's a lot of things that may be playing into this effect, and it's something that we really need to look further into. There's a number of limitations with this study. Like I said, very low representation of patients with Medicaid, and an unequal racial distribution with 95% of our patients being Caucasian. And then we also only looked at delta CNC at 3 months just because of completeness of data. But really, there is an important question here about long-term outcomes, loss to care, and things like that. So future studies will hopefully look at some of those longer-term effects. So in conclusion, national ADI is a robust measure for social determinants of health, and it's easily implemented across CI centers to better understand and evaluate equitable CI healthcare delivery. And this study is an important first step in evaluating social determinants of health and their impact on CI outcomes. I want to thank our team, including Dr. Xu, who's not able to be here today, Dr. Sabina Dang, and Carmela, who did a lot of the work, and Dorina was our statistician. These are our references. And then you can email Matt Xu if you have questions.
Okay, I'd like to thank our presenters for this fantastic work and for staying on time. We have ample time for questions. I realize we're keeping you from lunch and being, maybe first in line, but this is your chance to pick the brain of these experts. I know Dr. Holcomb has got a question. Yes, over here.
Great presentation. Just for Dr. Gomez, when you're looking at the physical inactivity that led to a longer wait time, were there certain groups within that data that was either like non-Hispanic, Hispanic, or was it just skewed as well?
So our population, they were mainly Caucasian patients. So we had like a few percent of Hispanic, and if I correct, it's like 5% Black African American, and it was like 5.8% Hispanic population. So this is one of the limitations of our study, that our population wasn't very diverse. I think in the future, if we do multi-center studies where we include more diverse population, we can determine whether physical activity had more impact in certain population, or whether it's more like a confounder factor associated with other factors.
Thank you.
This was a wonderful panel of speakers. Obviously, I'm biased with Dr. Volandia, but all of you really presented some interesting work on different populations that are being served in the U.S. So really, for any of you or all of you, what's maybe one thing that your study has made you think about, like a possible solution or a possible area that you can implement some sort of countermeasure or change to maybe positively impact some of the numbers that you guys presented today?
That's an excellent question. I can go first if that's okay. So in Arizona, we really have two challenging populations, Southwest region in general of the United States. So our Native Americans are who we spoke about today. Our Spanish population is also quite challenging. Actually, they have poorer access to care even than our Native American patients. There's a lot of reasons from that, but one of the things we've learned from our research and our interactions, not only with the healthcare providers who are helping send those patients over and co-manage them, but just from the interactions with the patients themselves, is you cannot use a homogenized approach to these different cultures. the different cultures will approach care, and this was talked about, I think, really well in this panel, very differently one to the next. So families a lot of times are very unwilling to seek care for themselves, for instance, but they will seek top-notch care for their children. We also see some issues in terms of the role of gender in the household. So a lot of times our female patients are less likely to make a critical healthcare decision, and there may not necessarily be a male figure in some of these families to be able to do that. So those are some things that we're working on, trying to reach folks where they are at.
I will also say that this panel make us a reflection of how we need to continue, and I think collaboration will be key in order to include more diverse population in these kind of studies.
And I would just say, I think that most of our projects were all quantitative based, and I think that the way that we actually get to more solutions approaches, maybe having more mixed methods or qualitative approaches, so that we can actually speak to those folks that we're running the stats on.
Rebecca, I was going to ask you about NHANES, and do you think these are the right questions for that population? I was just feeling like, ooh, we need to ask maybe some appropriate questions, like if we're not getting some answers that seem to conflict with what we might perceive. I don't know, what are your thoughts about that those NHANES questions for other populations?
Absolutely. I think we're kind of limited by what was available in the database. Thank you. But I think having more questions about, like we've talked about today, like access to care, exposure to information regarding amplification devices and interventions, those might be also helpful kind of moving forward and thinking about this in a kind of prospective study as well.
Yes, another question here.
This one's for Dr. Stevens. So in light of what we had kind of reviewed when it comes to insurance coverage, I also am from Missouri, where adult Medicaid does not cover cochlear implantation. So looking at your Indigenous patients and the amount of kind of loss to follow-up or decisions to not pursue CI, how much do you think that has to do with lack of insurance coverage or personal costs that might be prohibitory?
Thank you for the question, and that is an important question. So a couple things, I guess, to clarify on that. So when we look at insurance with our native population, actually out in Arizona, as was mentioned, our state currently does not cover adult CI under Medicaid, and that's something we're working on. We're actually pretty close to getting that back into law. But ironically, a lot of our native populations are Medicare. What we have run into is that they will be approved through Medicare, but oftentimes without a secondary or a supplemental coverage, they cannot afford the out-of-pocket even with that percentage of coverage. So the family will oftentimes, if they drop out due to insurance, drop out due to out-of-pocket concerns with the lack of complete coverage from Medicare. So we've seen that a lot more. So one of the things we've counseled our patients on is to make sure that they can either at least temporarily elect or for some stretch of time elect a secondary coverage. And then the other thing that we've run into is our hospital administrators, if we do the patients through the main hospital, which a lot of them are, we have to make sure that they are reporting to the hospital, the patients are, that they have a secondary coverage. Because a lot of times they'll show up on their day of surgery and the hospital will notify them that they have a huge out-of-pocket bill because they never reported their secondary coverage. The patients didn't know to do that. And so then they'll panic and they'll actually leave before I ever get a chance to talk to them. And they'll have traveled sometimes 200 miles one way to see us that day and get their surgery, and not realizing that they actually do have that coverage. The hospital just didn't know about it. So some unique hurdles with that population for sure.
Yes, another question here.
Well, thank you guys for the presentations. It's really a beautiful thing to see so many diverse cultures, attitudes represented in our group, and it's changed a lot. So it's an important thing to say, hey, we have allyship when we are not representative of that group, and thank you for the work you're doing. It's really difficult. Dr. Valandia, you made a comment that I just kind of wanted to ping in my brain, but it was a really beautiful thing to say. Look, we often think of languages as a a monolith of how language functions in the brain, but you brought up a really beautiful point about the fact that as a bilingual, multilingual person, you may actually intermix language in your brain, like we know with code switching, and that treating someone like a monolingual speaker probably just isn't accurate at all. So if you use that business language in one way, you're actually intermixing it with your casual vernacular, and so it may be a different test condition altogether. So I thought that was a really valid point. And then Dr. Bell, to your data, I was kind of curious if you've looked and extrapolated some of the information about how different generations, and to the panel at large, about how different generations approach care, because we see in the Spanish population in your data set that they engage with healthcare solutions a lot less, but does that change as they've been acculturated in a US model or into an international model more, and do you see differences in that data?
Unfortunately, we didn't really look too much into those nuances, but I think that's a really good point, kind of moving forward and thinking about particularly the Spanish-speaking population, how those things might influence their kind of access to care and pursuit of any sort of treatment. I guess we did include age in our models, but that doesn't really address like behavioral changes and patterns.
I wanted to add to Dr. Holcomb's question. For a long time, we have a standard test battery in English, but we don't have one in Spanish. So that's something that we are going to start working on to have, because I feel that this Spanish population is rising in the United States. And I feel that since we have a large population in Miami, we have found ways to test these patients for many years, but there are many centers that have only English-speaking audiologists, and maybe they don't have the tools or they don't know how to use the tools that are currently available, and I feel that is important for them to have a minimal test battery that they know how to use, how to implement, for them to know how to assess these populations and where to move and how to determine if they are candidates or not. So that's something that we are going to start working, and Alejandra is leading this effort that we're going to start.
Do you have a rebuttal, Dr. Holcomb?
No, I actually just had a comment for you, Dr. Bush, since you're a new member of the ACIA board. I think we can all agree who are in this room that this topic is very important, but we can also agree by looking around that clearly there are not as many people perhaps as engaged in this topic as there should be. So what do you think the ACIA can do to make that better?
Well, we'll work on it. As a short answer, I think you have seen kind of some amazing highlights of really high quality, very thoughtful research that's very culturally sensitive and appreciative. But we also need to invigorate some opportunities with research funding and specific mechanisms that would promote equity. So I think there's some research initiatives that we should investigate, as well as better messaging about highlights. And for everyone else that's not here, they missed the best session. So it's kind of a letdown for you for the rest of the conference, because this was the high point right here. Dr. Smitak, I want to thank you for presenting, pinch hitting, and being a part of the team. I think this is really important research to use this area deprivation index. I'm curious about insurance and these poor outcomes. Do you think that may have something to do, or did you look at like the actual utilization of care, such as was an insurance a barrier to appointments, like number of appointments post-operatively? And maybe they were using their device, but maybe their programming wasn't appropriately because they maybe couldn't come to post-op appointments. What are your thoughts about that?
We didn't look at least to my knowledge, we haven't looked at that specifically yet, although I'm sure it's in the pipeline. But it's an interesting question, and I would imagine that all of those things that play in, but I don't know specifically. Certainly, part of why we had to use the 3-month score is because we don't have longer-term data, and so there is probably dropout. There are probably patients who aren't coming back to those later appointments and really optimizing their outcomes. So long-term outcomes are going to be something that we need to look at.
Yes, please.
Hi. Oh, I'm sorry, I'm short. There we go. Thank you all for the talk. It was probably my favorite here of the whole conference so far. One of the talks I went to yesterday was from a social worker who was working with cochlear implant programs in Canada. And I know y'all work at, a lot of you work at major institutions. I was wondering if you were involved with social work, because I can think of the insurance aspect may really be helped with a social worker to help navigate people through that.
I can speak anecdotally to the team in North Carolina. The pediatric team does have a social worker as part of their crew, and I have interacted with her myself and know that she is a blessing, but our patients reiterate that to us all the time. I think she helps connect them in ways that is just really special, so she's a very integral member of our team.
I'm in University of Miami, and we're very fortunate to have a social worker. And she started just working with the pediatric population, but we have a large need with the adult population. So she is now being helped by students. She finds ways to get the students to come and help her because she is not enough for all the population that we have. And I not only do cochlear implants, but vestibular, and then I also do auditory brainstem implants. So she has been helping all the patients that we see in different scope of practice of audiology. So it's very crucial to have a social worker in a practice because not only with insurance, but there are so many social needs that the patients have that don't allow them to get into cochlear implants. And that's one of the things that we have to address before we think of implanting these patients, and before and after.
I want to just add one really important part of social work for us. For those of us in states where Medicaid does not cover cochlear implantation, a lot of those patients do qualify for disability and can transition over to Medicare. But they just don't know that. And so helping them go through that process can get a lot more patients qualified.
And I was just going to say, at UCSF, we have a multidisciplinary hearing clinic for pediatric patients, and we have social work, audiology, SLP, and the otolaryngologist all on virtual. And then we also have included a patient navigator now, which is why I did the plug for the 1220 talk on Saturday.
Yeah, in Arizona, we definitely have social workers for our pediatrics teams, and you absolutely have to have that. For our Native American patients, though, we don't have that. And so one of the problems that we run into is we have to do all that work. So the way I conceptualize the blessing of having a social worker is that is basically an inertia-lowering element on your team, meaning eventually your team is going to get burned out from doing all this extra work and may just give up on cases just for sheer lack of time and man hours. And so I think aside from our primary CI teams, really we should probably all have social workers. And I think that one element could potentially lower the inertia enough that we may be able to get more and more patients through. So that's a really great point to bring up.
Yes, sir.
Fred Talishi, Miami. Thanks to the whole group for your presentations. Dr. Stevens mentioned Medicare. Dr. Smitak, I think, maybe alluded to it when she was talking about the government group of patients. Is there a difference between managed Medicare and straight Medicare, or have people noticed a difference in terms of access depending on what type of Medicare the patient group happens to fall under?
That's a very good question. So I don't know that I can fully and adequately answer that. What I can say to that experience is the vast majority of our patients on Medicare, and this is anecdotal, my opinion, they really don't know much about their coverage. They know they have Medicare. They can't tell you what their plan is. They can't tell you what their supplemental is. Sometimes they don't even know or remember if they elected a supplemental. So it's a challenging group. We have to really help them navigate that. I would say the managed plans are probably a little bit more difficult sometimes, but I don't know that I would be able to say with any kind of surety or data one is different from the other. in some ways just a challenging group overall.
Yeah, I don't have much to add to that. We haven't necessarily looked at them separately. That's an interesting question.
Yes, please.
Hi, Dylan Chan with UCSF. I just want to thank the panel. This is such an amazing and diverse group of speakers here today, and I think it represents the future of our field. And we're at such an interesting point in disparities research in hearing healthcare, because we've identified all these disparities and we're trying to identify interventions. And a lot of us brought up things about social workers or navigators, and questions always come up about who's going to pay for these interventions and how there are no billing models for these types of interventions. And I think we're at an amazing point where we can develop research projects that prove that these interventions have the same kind of clinical benefit that we do as otolaryngologists or that audiologists or speech language pathologists have. And that if there's some way through ACIA, that through designing research studies or advocacy, that we can develop these models to prove that these are critical and billable services by social workers and navigators. And there are some models like that in different states. So in California, through California Children's Services, social workers can bill for care coordination. And I think if we can learn from each other about how these billing models can exist, that will, and create the evidence for it, then we can make this a reality across the country. Thank you.
Well said, Professor. That's a good way to finish strong. So thanks to our presenters for excellent presentations, and thanks to you, and enjoy the rest of the conference. Go enjoy lunch.